So we're recording now. This is for anybody that misses it, can actually listen to the. So we're talking about the team that's doing the app for the contact tracing. So this South Korean app allowed, basically it was, South Korea is a pretty repressive regime, and so the point was to have people geolocated, and if they escaped or tried to leave their area of the quarantine area, they were actually dispatch the police to arrest them and bring them back to their quarantine. And so it worked actually very effectively, which is scary because this type of structure works well in the repressive regime where people are forced to quarantine. It really hasn't been tested in our environment here, where people can have the freedom of maybe saying, no, you can't arrest me. I have a right to infect people. So we came up with this idea of copying their app and copying its features, and which they actually facilitated. And so we have actually an app developer who's a volunteer who actually works at the hospital, who's working on it. So the way the app works is you register, you give your geolocation. Of course, in the United States, you have the ability to say you don't want to be followed. So you can say, no, I don't want to facilitate this feature. But you've all been hearing about the Apple app and the Google app that's going to be able to tell you who's close to you that's positive, or if you've frequented a place where somebody was positive. So obviously, if they do check that they're allowing us to geolocate them, we're going to be able to maybe share that information with Apple or Google app. And so then that'll give a bigger pool of locations. But our purpose is really to just follow these people and to allow them to, so the way it works in South Korea is you're supposed to report your symptoms twice a day. Of course, repressive regime, if you don't report twice a day, you get arrested. So our purpose here is a little bit different. So our purpose is we know that when you get coronavirus, if you can go from having shortness of breath to going to full pulmonary respiratory arrest and end up needing to be intubated, and if that doesn't happen, you can die. And last month, there's some statistic, and again, this is something I've heard, I haven't confirmed, but that there were an additional 2,000 deaths in New York City. People were found dead in their apartments, more than the normal month. And so the theory is these are people that probably had coronavirus. They just didn't have the ability to understand how serious the condition was. And one of the first weekends we had the support group, I remember actually Wendy called me and she said, we didn't have actually a lot of Hispanic volunteers. And she said, we have this person, she's saying something about falta de aire, which means shortness of breath in Spanish. And so I called this lady because I was the only one that could speak Spanish to her. And so I called and I said, you said something about shortness of breath. And she said, I never said I was short of breath. And I said, well, you said something that sounded like shortness of breath. So she said, well, yeah, what I said was that when I go to the bathroom, I get short of breath. When I go to the kitchen, I go short of breath. But normally I'm not short of breath. Right now, I'm not short of breath. So I said, well, you need to go to the hospital. So I ended up at Baptist emergency room. And she had actually pneumonia, and she probably would have been found dead the next day. There was actually a nurse at a local hospital, Palmetto, where she's in the 30s or 40s, had a minor kid. I know you must have heard the story. Her husband found her dead after she was diagnosed positive. So obviously, there's a reason why we want to monitor whether somebody checks yes on shortness of breath. So if they report twice a day and they report shortness of breath, then our agents or volunteers that are going to be assigned these patients are going to call 911 or call them and call. And if they don't report symptoms, they're going to call them and find out why. And so this is set up so that we have agents and patients. The agents are actually part of Team 10, which is the contact tracing team. And so if the patient doesn't report symptoms, they're going to get a page informing them. And if they report shortness of breath, they're going to get a page informing them for the 14 length of the quarantine period. They're going to also help obtain the proof of COVID positive to prepare them for plasma donations at a future time. So this is how we kind of structure all that. So this app is really great. I think Camilo is going to give us a little update on it. I think he just submitted it to Apple and to the other platform. We have team 4, which is a basically clinical guidance team. A lot of the residents are involved in this team. We had a team 5, which actually met its purpose. In Virginia, we're about to retire team 5 because this is the volunteer engagement team, and we kind of engaged everybody. Okay, that's Virginia. So I think we're ready to rework team 5 into another team. Mission accomplished. Team 6 is actually a team that needs a lot of help, and the idea for this team was to create a national staffing registry. So the idea is healthcare providers get sick, they have to be quarantined for 14 days. And so if we have a national registry of nurses and doctors and health professionals that are willing to work with COVID, the question is, how do they get to the hospitals that need them? And so the idea was to create a free registry. So I don't know if anybody listening has abilities to do that, and it's allow them to register for free, put in their information. I'm a nurse, this is my license, upload everything in there, and then let employers go in there and say, oh, wow, there's a nurse in my area that I can hire that has experience in ICU or emergency room, and so I don't have to go understaffed. So I think that'd be great. Then we have team 7, which is basically a convalescent plasma community engagement team, where we basically go on the radio, TV. We have a Spanish, English, and Creole line where people can call to donate plasma after they've tested positive. And then their idea is once they get that, they move them into a leads team, which is team 8. That team gets all their information, including their positive COVID, and then they send it to team 2, who closes the deal with the donation. This is why we have 34 plasmas, because we have an army working on it. And they're all volunteers. Team 9 is a discharged and recovered for people that are discharged from the hospital. And then team 10, which is probably the most important team, and the team that's going to allow us to go back to work, which is basically a contact tracing team. And that team's purpose is to really contact trace and go back 14 days and basically help find out who the contacts were and bring them, either put them on quarantine or test them as required, and then be able to break that the chain of contagion. And in that team, there's about 270 people, all over the United States. So we divided the country into 10 geographic regions, and so there's people in every region, and they're actually forming subgroups in WhatsApp. Within that team, there's a social media team that's actually encouraging more people to come in. Most of the team 10 team members are foreign medical graduates or medical students, so they're actually pretty well equipped to handle the contact tracing piece of it. We're in the process of developing what criteria you follow for contact tracing. We're trying to borrow from the Ebola stuff. So that's kind of a summary. Let me start with team 5, Virginia, which is the retiring team that we just accomplished. And
Actually, Heather is going to tell you about the status of team 5.
Okay, Heather.
Hi there. Just real quick, I'll tell you what we did. We contacted the initial call to action that Dr. Michelle had. So we contacted the 300 plus people that had interest in doing some volunteering. So we got in touch with them, and it was everybody from hotel owners to caterers to anybody that's in the medical field. They're now going to be sorted and separated into the teams that the categories that they kind of fall under for what their skills are. Virginia is working with all the team leaders, and she's working on a plan just so that the gears can kind of continue to run smoothly. Some of the people that were volunteering aren't available anymore, but I think that they have a medical license and we should still forward them into team 6. I think that's great because that's the database, the national database. If the country, starts opening up as expected, then there may be another call to action. And when the volunteers start to reach out, they'll be placed directly into the team. They'll be able to choose which team they want to go into. And then the team leaders will contact them from there. Anything else, Virginia?
No, I think the difference is that when we first started, Dr. Michelle, when you first started putting out the call to action, people were streamlining the volunteers into one place. And now we're trying to put the word out and disseminate the individual groups' heads so that when somebody's at home and they want to volunteer, they can actually go through an assortment of options and then send an email directly to the head of that group. And that'll make this more streamlined and people can kind of choose where they go. And hopefully that will continue as the word gets out and people know more about the efforts. So thanks for letting me be a part of it.
Thank you. Everybody, Virginia's a lawyer, so if we ever get sued, she can help us out.
Please don't even have to think about that.
All right, so team two, good job, team one. Team two, convalescent, oh, I'm sorry, wait. We're gonna do team one, which was that was team five. We're gonna do team one, which I don't know if Wendy's back. Wendy, if you're back, holler.
No, but I can speak for team one.
Okay, sure, go ahead. Team one.
Okay, team one. So basically we call the health, we get the health department list and we call each patient. We're up to 900 patients now on the list. And they get sorted to different categories, the plasma team two, and then group therapy and case management. And thank you for all the Spanish speaking dentals for helping me. But we're up to speed and we're communicating with team two and getting the volunteers to organize people running groceries to households that need it, and group therapy is being organized as well. So that's where we're at.
Thank you. Thank you. So Camilo, team three, do you have a little presentation for us so it can be an all for your, Camilo's been working nonstop on this. Camilo works in admitting at Larkin, and he sent me an email one day and he said, I can do this app for you. And he's been working as a volunteer doing it. Camilo, you there? All right.
So,
there's a lot of
there's a lot of feedback. Is that better?
There's something wrong with your audio.
I have like a lot of tools open, I'm sorry.
Yeah, that's a little bit better.
This is better?
Yeah.
Okay, can you see my screen?
Yes. So we're going to change that by the little, we have actually the COVID.
Yes, I started adding that on where I can definitely add that on. It's going to take a couple seconds.
Okay.
So basically this was submitted.
You submitted this to Apple already and to Android, right?
Yeah.
Okay, good.
I believe that we're going to get streamlined in Apple. We should have released by Monday.
Okay. So those are the three simple. Let's go back a minute. Let's go back to the beginning, because I wanted to see the functionality real quick. So start from here, and then this is a free app. You download it, and then the next thing that you see is registration. Let's see the registration.
Yeah, that was a loading screen, and it goes straight into the sign-in and registration page.
So then when you register, you put your name, your email address, okay, and then let's go back a little bit. And so it allows you to actually select whether you want to be geolocated or not. And then this is when you have to do symptoms. So it says, if you click yes on shortness of breath, that's when your agent gets a text saying your patient, your contact is having shortness of breath. So then that's when they call you, and they call the patient, or they call 911.
So right now the sign-in was auto-detecting me because I kept going through the video, trying to make sure that it auto-detected.
So the idea is to launch this nationally and to allow agents to be assigned locally. So basically, this could be adopted by a local health department somewhere in Alaska, and they could assign their own agents. All we have is just the data. So we'll keep the data, but it could be unidentified data. So it could be used for either research or help improve the application. What are you doing now?
Okay. I had another app, but I'm not sure if you guys can see this side now.
Yeah, we see that. What is that?
Okay, so this is the patient management side.
Okay.
Every 12 hours, if they don't report, you're gonna get a time alert. It's not sending the messages yet, just because I'm not trying to run the quota.
So tell them a bit about how expandable this is. So we can go up to hundreds of thousands of people, right?
Yes, this is an
So
open.
this is on Google. This is on Google Space or something, right?
Yes.
And then the texting is also through mass texting that allows us to send hundreds of thousands of texts.
Yes.
So this is all designed so that you don't use your own personal cell phone to text people. It's actually designed for a mass scale.
Yes. Yes. So somebody can report, and it would generate an alert here for shortness of breath. And it's already in real time syncing. So right now, if somebody was to log in, let me see, I can assign somebody.
It's okay, Camilo. I don't want to go into too much detail. What else do you want to show?
Yeah, that was pretty much it. I have that and the user management page, which is
okay. So this is what the users, this is what the agency, which is what alerts they're having, right? So they say who has shortness of breath, who doesn't, and then this is how you assign agents. So, for example, if Alaska wants to assign their own agents, you can actually assign their agents for them, right?
Yes. Yes.
And how many shortness of breath alerts you have and everything else. Okay. And then so part of this also is it asks the possibility for the patient to upload their COVID result. By doing that, then it facilitates the plasma donation. So by the time they don't have symptoms, because sometimes it could take 2-3 weeks to get the COVID positive test back. Okay. Anything else you want to talk about, Camilo?
Yeah. That's pretty much it.
Okay. All right. Good job, Camilo. So when are we going to hear back from Apple and from
Android? I believe they're going to streamline us. They're going to let us do beta already on Monday. They should already approve us for beta. Okay. Apple is going to take a couple more days. They say that they're expediting healthcare apps that are fighting COVID, but that they're also trying to review them because there's a lot of spam and a lot of people. And there's obviously a lot of people putting a lot of apps up into the Apple Store right now, and they're actually under demand because they don't have the staff.
Yeah, and actually the team, some of the Team 10 people did some research on what the apps were out there, and all the apps are about, most of the apps that I've seen in the US are about whether somebody was positive in your area, which to me is a total waste of time. I mean, I think this is the app that we need, which is basically allows you, thank you, John. I didn't know the people in the waiting room. All right. I didn't realize, I didn't, okay, got them all in. Welcome, people. Welcome, everybody. Sorry I didn't see you. So we have 164 people logged in right now. So anyway, that's the plan with that. Okay, let's, thank you, Camilo. You can take the screen off. So Team 4 is the clinical guidance team. Anybody from Team 4 want to say something?
For Team 4, how are you? Basically, we're putting together a protocol. There's a lot of new treatments out there, including, you know, when to use steroids, when to use plasma. Sorry, Dr. Yatskin's here. He's making a lot of noise. But basically, you know, internal medicine, and we are trying to put everything together. Ozone therapy, I'm in the process of getting that put together. I'm going to stop by your office, Mercedes, so we can set up Dr. Fran so we can start the ozone therapy.
Hey, John.
Starting to use Zofluza instead of Plaquenil at this point.
How's that going, by the way?
Yes. We started our first 2 patients on Zofluza for the first time in South Miami. So, I mean, nothing any different. We started it early, so we're waiting to see if it actually works or not. So
what we're doing is we're kind of randomizing our patients now, the ones that are coming in, that can be managed kind of on the floor without needing, more critical care. We're randomizing them to azithromycin and Plaquenil versus azithromycin and Zofluza. So so far we've had 2 patients on the internal medicine service that we've put on Xofluza, and you know, we have obviously the other ones that we've placed on Plaquenil to see between the 2 medications which one, you know, is going to be more effective. It kind of gives us, you know, an opportunity to run a different, you know, a few different trials, but also at the same time, you know, assess the efficacy, because, you know, we've been looking, we haven't really found much, you know, evidence on the use of Xofluza in this case, other than some anecdotal evidence. But, you know, if we don't try it ourselves, we're not gonna, you know, find anything. Obviously, we know a lot about Plaquenil and all the studies that are coming out, and some more recent studies have come out with some mixed results. So basically, what we've done is we've come up with a protocol that I think was sent out. I'm not sure. If not, I can send it out again. Where we've divided patients into, you know, based on their symptoms, into mild, mild with risk factors, moderate, severe, and then obviously when they go into ARDS. And then based on that, we've come up with treatment algorithms to, you know, when to start them on, you know, Plaquenil or Xofluza, when to start them on steroids, you know, in terms of anticoagulation use and all that, all those kind of things to kind of streamline what we're doing between the 2 campuses. I don't know if Palm Springs is also following the same protocol or not. I know they had their own protocol initially, early on.
Yeah, I gotta say something. Yesterday, we were trying to get integrate the 2 groups. Basically, it's 2 groups: it's Spring and also Larkin South. However, there is mixed. There's resident for Larkin South that is working in Palm Springs, resident for Palm Springs working in the ICU AD in Larkin South. So the best way is to communicate each other. There is so much information, and we're still trying to figure out and include everyone in WhatsApp group. The reason for we starting Xofluza is that Japan showed that it's more effective in the influenza and it's faster. It's only 1 dose compared to oseltamivir. New York started using oseltamivir with the azithromycin and the Plaquenil, and this shows some results. The things that they have different target of action, and the action is very quick. So we can do like a trial that we're trying to figure out how to do, because there is no trial in the world about this. So that 1 branch could be azithromycin Plaquenil, 1 branch could be Xofluza with azithromycin, and the 3rd one could be Xofluza, Plaquenil, azithromycin. The only difference is that when we use Xofluza, we cannot use PPI or anything that could produce alkalinized in the body, because it's gonna decrease the action. Also, lactose are contraindicated. And Xofluza cannot be used in ages below 14 that have been shown that they increase the mutation of the virus. So I think it would be a very good idea. I was discussing yesterday with Alina that as early we start the Xofluza would be better. So that we know this is a symptomatic patient that has positive COVID. The patient doesn't require hospitalization. We can figure out because give Xofluza and follow this patient. So that would be another trial. But so far in Larkin South, we're starting with Xofluza with mild, moderate symptoms, additional azithromycin in 1 branch. If we have enough patients, we can add the third branch that would be Xofluza, azithromycin, and Plaquenil. There is no contraindication for you both. There is no reaction between both medications. So in that thing, we have tried to avoid the confusion. So if we have the 3 branches, we can figure out which one is working better. So far, we're starting with Xofluza. 1 dose, 40 milligrams, maximum, adjusted the body weight until 80 is the maximum. So yeah, we have 2 cases, and Palm Springs is going to implement. So we have the support also of Dr. Molet and Dr. Yasker, that are in both hospitals. So I don't think it's going to be an issue to start the trial also in Palm Springs.
Another thing that we started talking about yesterday, and we're trying on a few patients, is we have seen a lot of, and there's been reports out there that the pathophysiology and the findings are very similar to high altitude pulmonary edema. And we know that the use of medications such as acetazolamide or nifedipine has been shown to be effective in high altitude pulmonary edema. So we are now trying to see if acetazolamide has an effect on any of these patients with nicardipine, the hypertensive ones. We can put them on nifedipine, see if that shows any effect with them. We had 1 patient in the ICU who was very hypoxic despite high FiO2, despite high P being on a ventilator. and steroids. And after they received the dose of Diamox acetazolamide, their oxygen saturation went up tremendously. You know, their PO2 went up. So that made us, you know, so that made us think that, you know, maybe there is something there. And so if you look into the literature, you're seeing that they're describing similarities between pathophysiology, the respiratory pathophysiology of COVID versus high altitude pulmonary edema. So that's another thing that we're looking into to see if there's any benefit in using those.
Can I ask a question?
Mm-hmm.
Has this team looked at the role of like IL-6 inhibitors, IL-1 inhibitors, IL-12 inhibitors, or IL-8 inhibitors?
Yes, that's the last tool that we're using. That's the last weapon. Once you have the strong cytokine, the patient is complicated. It's not any other treatment is not working. So every patient should be about, with the interleukin 6, about 40. So that means that we are in the cytokine storm. Tocilizumab is the one that we have used in 2 of our patients with successful. Let me tell you something. We have been Larkin so far around 55 patients hospitalized. We have 0 deaths. Even we have 2 very complicated cases that we were discussing with our leader, Dr. Michelle, said, oh, I think those 2 patients are going to pass. And we try everything. In addition, the patient started having renal failure, UTI with hemodialysis. And we try in those patients, very complicated, the plasma, and it was a miracle. The patient started recovering. So far, we have 0 deaths. We have from 8 intubations, we have extubate 6 or 7 already. I'm not there, but I think so. And only 1 remaining intubated. So that's an amazing result that we're having Larkin South.
Well, one thing I should say, you know, I got a call from the cruise lines from Carnival a couple of days ago. And they asked me, like, what are you guys doing? And I said, well, are you doing something bad? They're like, no. It's like your outcomes are so much better than the ones of the other hospitals that we send the patients to. Like you had very few deaths, and it was basically people that were kind of dead before they got to you. But they were just wondering, like, what we were doing that was different. So you kind of reinforced why, because I think, you know, as a teaching hospital, we're doing things that maybe other places don't do, or, you know, we're not, things that ozone or Sofluza or some of the things you're trying.
Yeah.
There
is one more thing. After round, Dr. Michelle always tells, also pray. This is important. So we're doing that.
Very good.
Hey,
Alberto, go ahead.
Real quick, any chance that you'll be using any of these IL inhibitors earlier on in the algorithm versus at the very end?
There is no point. You have to have in a cytokine storm already, so the patient is having because otherwise there is 3 cytokines activated. Interleukin 1, 6, and 8, and so far the result we're having is not early, but already complicated patients.
All right, very good.
Umberto, sorry, I have a quick thing to say. We had a patient, it's Ferial here, in the ICU when we were there, patient in ICU bed. Umberto, I'm not sure you were there one of those days when we used Actemra on that patient. And he was right at the cusp of his cytokine storm when we got the accurate history from him. So I do believe we don't have volume to truly test it, but I don't think that medication is truly off the table. I think that we are seeing it. I think we need more volume to test, and there's really no way to know if one is working superior to another, but it worked for that patient, and I'm actually writing a paper on him.
Good. But so far, all the research that we have reviewed, it says that it has to be in complicated patients when you have all the markers about 1 level, even combined. So far, steroids, anticoagulation, and the last 2 is the interleukin 6 inhibitor, the tocilizumab, the one that we use at the end. So far, in complicated patients, the big tools that we have is anticoagulations and steroids.
Right. I totally agree with you, but all the papers are testing different parameters. So there's no way to say what has effectively worked. And again, the volume is not enough to make definitive conclusions.
Okay, guys, let me just, I'm very impressed with the exchange and everything. And I think we could discuss this on the Team 4 individual meeting. I don't want to, because we have a lot of people from different teams here. I just want to kind of give a quick introduction. But thank you so much for the passion and for being engaged. I think I skipped team 2. I'm sorry. Convalescent plasma. You guys had a report. Go ahead.
Hey, so me, Monica, Patrick, Vanessa, Freud started up team 2. Now we have a bunch of dentists and other people on board. But basically for the past month, we have been trying to collect plasma from patients that were tested at Larkin, tested positive. So we're working closely with Laura's team and Masha's team. They're asking the patients if they want to donate, so we don't have to cold call. Once we know they're interested, we give them a call. They have to be 14 days without symptoms and have a negative nasal swab in order to donate, or 28 days without symptoms. So what we're finding is when we're testing them at 2 weeks, I would say 70 to 80% will still test positive, which makes it challenging. So a lot of them have to wait for the 28-day mark. But so far we have about 188 people wanting to donate, about 34 on our list ready to donate and that have donated. And Dr. Jack Michelle is right. Everyone that has needed plasma has gotten it at Larkin Community Hospital. I don't know if anyone else has anything to say. That's all I have to say.
Patrick?
So I've been trying to get a clinical trial going, and I submitted to the FDA yesterday for a IND number, which is an investigational new drug number that we could potentially use instead of having to get an emergency one every time. But I'm not sure if they're going to give me that number or not. In the meantime, I'd like to talk to you, Dr. Michelle. Maybe we can start not randomizing people, but just giving it within the first 24 hours of presentation to the hospital.
Absolutely. Do it.
And
Absolutely.
then we can just compare it retrospectively. And then if they approve our IND number, we can start the trial then.
Do it. Absolutely. I mean, this is about saving lives. So absolutely. Just go right ahead.
Okay.
And then I just had a quick question for team 4. Is the plasma transfusions, are they helping the patients?
So, so far, one patient actually we've seen improvement with the plasma transfusion. The only thing with us is that that patient has received so many different things, you know, between blood transfusions, plasma transfusions. I'm not sure if he got tocilizumab or not as well. That we're kind of at a point where we're like, we don't know 5 different things have been given to this patient. However, it did work with him, and he did improve, you know, showed an improvement after receiving the plasma transfusion. So far our number has been good with that guy.
Pedro, tocilizumab was contraindicated for the renal point.
Okay, so he didn't get tocilizumab.
No, that's the only thing he didn't receive. Yeah.
So just so everybody, so the problem we're having now is that we have plasma of every blood type, and we fulfilled all the Larkin needs. And there's no patient that's hospitalized at Larkin, either South or Hialeah, that needs plasma. They can't get it immediately. But the issue we're having is now all the local hospitals have a contract with a company called One Blood. And so that company, we initially, I think, gave them, how many units, how many transfusions did they get from us, Patrick? Was it 6 or 7?
You talking about the other hospitals?
No, the One Blood. How many patients did we give them?
Probably like 5 or 6.
And we ended up with like a couple of bags of plasma, right? Or something like that.
Well, they went to the nationwide blood hub, which is like a conglomerate of like all of the.
Right. So what was happening was the plasma was kind of disappearing, and it wasn't even available to our patients. So we found a new blood bank called American Blood Bank. And this blood bank is actually guaranteeing us that the plasma is going to be used for either our hospital or for local hospitals. So far our hospital has gotten how many units so far? 7 or something like that, right?
Probably about that, yeah.
And then we gave 1 to Palmetto, 2 to Holy Cross, and we're working with a bunch of other hospitals. But what's happening is we're getting calls from patients and from family members saying, my loved one is intubated at XY hospital and they need this plasma. And we have the plasma, but the hospital administrators have difficulty in understanding how they can get the plasma done. They don't have a contract with American Blood Bank. They said they have an exclusive with One Blood. And I keep telling them, look, you can have an exclusive with anybody, but if the patient's, you're not going to let the patient die that could get this maybe life-saving treatment. So we're thinking of creating a second team, and the purpose of that team is going to be basically to work with patients, not so much patients, but patient family members and other hospitals, and try to kind of go through the maze of what do they need from American Blood Bank to be submitted to them, and how do we get this done? Because right now we're like stockpiling it. We have 34 units, and there are people that are still dying because they don't have the plasma. So anybody that wants to volunteer for that team, email me. We'll have like team 11 or 12, like 12, I guess, to be team 12. You think that's a good idea, Patrick?
Yeah, I do.
So we're gonna start that. So let me keep going. So we have anybody from team 6, which is the staffing registry. I don't think there's anybody. Is anybody on the line? So team 7, anybody from team 7 that want to give a quick talk about Dr. Flora, you're on the line? Anybody else from team 7? All right, team 8? Laura,
I'm here. Yes.
All right, Laura.
Hi,
Tell them a
how
little
are
bit about
you?
who you are and what you're doing and your great team of volunteers and what's happening.
Good afternoon, everyone. My name is Laura Salazar, and I'm representing the team 8. We are 10 volunteers at this moment, and what we do is that is in charge of calling the leads sent by the Convalescent Plasma Community Engagement Team 7. We're taking care of both Spanish and English calls at the moment, and we check with the possible donors and convalescent patients, and we check that they have been completely symptom-free for 14 days before they can donate, and we get a copy of the actual positive test. Then when they qualify, we can refer the possible donor to the team 2 with Andrea. We're working close to Andrea, and basically that's it. We started doing calls April 9th, and we have made so far 139 calls. From them, we got 8 qualified donors that they already referred to the team 2, and 8 persons that they did not have been tested, but they're able to do the antibody test, and in addition donate the plasma, and they are already referred to the team 2. And we're working with another 5 other people who were positive, who were tested, but they were not able to give us the test. So we're trying to locate those tests at the moment. And basically our daily goals is making all the calls needed, follow up the results, and get the most possible donors as we can.
Great job, Laura. Team 9, the discharge recovery team, Tamanshi, or who's there?
Susie would begin. Okay.
Oh, Susie. That's right, Susie, I forgot. Yeah.
Hi.
So I can't see you, but
yeah, my camera for some reason it's not turning on, but we have a presentation.
Okay.
So Devanshi and I are just going to speak a little bit about what we do. So we're team 9, and basically our role is to reach out to those patients who have been discharged from both hospitals with COVID-19 and just ask them a couple questions regarding on their current status, follow up on their results, how they're feeling. And we haven't really gotten, we'll talk about it a little more, but we haven't really gotten the chance to do this yet since we haven't received the list, but we have made a script which we're going to follow once we start contacting these patients. And we're going to be asking them things, for example, about how they're feeling, what symptoms do they have, if they have any more results, then questions about their mental health, and then refer them as needed, let's say to team 1, questions about whether they want to donate their plasma or not, refer them to the appropriate team, etc. Yesterday, we also discussed about recommending any patients, if they are feeling symptoms or if their pulse oximeter read is low, to the ER. We're going to talk about a little bit more about the pulse oximeter later. And then we also just raise awareness in general, and that this is not a death sentence, and that people that have been diagnosed and discharged with coronavirus have lived healthy lives after leaving the hospital. So right now, where we are right now is that we collected a bunch of resources. We put them in a Google Drive. So for example, I'm a dietetic intern. So myself and my fellow dietetic interns, we found a really useful guide on nutrition for recovery at home after these patients are discharged. So we have that resource collected and we can use it once we're in contact with the patients and they might want more information about how they can heal or eat or hydrate themselves after they get discharged. We also are awaiting, like I said, the list of the discharged patients in order to begin calling them and distributing them to our members to make these calls. But according to Dr. Michelle in yesterday's meeting, we have implemented a legal release form for them to sign after they've been discharged so that they can agree to being called by one of our volunteers. And then we've also ordered pulse oximeters for these discharged patients to go home with. And my fellow volunteer, Devanshi, is going to go a little more into that.
Yeah, so hi everybody, I'm Devanshi and I've been working with Team 9 to, get the follow-up and discharge moving. So in one of our brainstorming sessions, a volunteer, Ang and I had come up with the idea that we could probably get into a more more objective assessment than a subjective assessment of just calling and asking how the patient is feeling. So that's when my fellow volunteer said that they have a protocol wherein they monitor pulse ox remotely in other parts of the world. So that's where all this came out. And then we thought we could reach out to people, and we were just having an idea what is the necessity for doing this. So just by having a pulse oximeter and basic monitoring facilities at home when the patients can self-isolate, we allow the ER to be decompressed and the staff can channelize all their resources appropriately so that more serious patients can be dealt with. It also reduces the anxiety that a patient who's tested positive would probably have. And since the patient isn't in the hospital setting, the risk of aerosolization reduces. So we're basically interrupting the transmission of disease and making sure that even the healthcare staff is a little better protected than having all the patients with risk factors within the hospital. So Susie, can you, yeah. So this is what the device that we have ordered looks like. Larkin Community Hospital has signed up with Expand Care. So there's a collaboration right now wherein we would be getting devices like this which would be a wristband. So it doesn't get misplaced and we don't have altered readings because of positioning. And what the patient technically requires is only a smartphone. It doesn't require access to internet because everything is done via Bluetooth. And all the information would be a continuous monitoring that is connected to the dashboard, which would be monitored by a team that we are still building in the emergency room or in the ICU, wherever appropriate. And there would be alarms that come about every time a person has an altered value for a particular range of time. So we are currently looking at SpO2 and pulse monitoring, although the device can also measure RR, I mean, that's respiratory rate and activity. But we are trying to go about with these two parameters as they're more predictive. And as soon as we realize that there is an abnormality, then the patient would be contacted and can be redirected to Larkin appropriately in time so that we do not have patients dying, just like Dr. Michelle rightly said, that there were about 2,000 deaths in New York and nobody knew why. So here we could prevent that from happening by being proactive. So that's what we're trying to do. Yep, thank you.
Thank you, Devanshi. And so some of this came from some of the Chinese data where there was a question about whether the virus was coming back. So people were being discharged home after having been diagnosed with coronavirus and having pneumonia, and then they would be back in the hospital again, brain dead because they were found somewhere. And so the concept was maybe they're just getting the virus again. Maybe there's no immunity provided by having recovered. Well, the data really shows that they never really recovered. So they were discharged too early from the hospital. And this is why the oxygen saturation monitoring is so important. So this is why we're going to combine that with also the temperature monitor and then we will have that monitored by people. So that's the idea. Anything else to mention?
We're going to go live with that on May 4th. We had a side meeting today at 11 o'clock, and Team 9, we have the people from California coming down to Miami to meet with us at Larkin South, where we will all be trained, and the effective go live date is May 4th, so that everybody out there knows that.
Excellent. We're going to go through the comments on the chat. I promise. I know you guys keep posting there, but towards the end, we'll go through those questions. Let me move on to Team 10. Obi, are you going to do it, or someone else?
Yes, I'm here. I can help with that.
Hi, Obi. We can't see you.
Hi. Yeah, one moment. I'm just going to share my screen.
Okay.
Yeah.
Well, tell them a little bit about who you are and.
Yes. Give me one moment. Yeah, can everybody see me? Or see the screen?
Not yet.
Okay, cool. Just give me 1 second.
Now it looks like something's working. All right,
Okay.
There you go.
Give me 1 second. Just be sure.
Oh, I like that word, thought leader.
Yeah. Yeah, so I'm just going to share my screen quickly. So we're Team 10, and we are we're the contact tracing task force. It's more like CT square. So that's our acronym. That's the way we pronounce ourselves. So, and within our team, we have an educator, that's our Chief Learning Officer, Dr. John Van Capel. He's going to be helping us with training of all the volunteers. And Dr. Jack is our thought leader and been guiding us for the last 2 weeks. So we had a presentation last week where, our panelists spoke, and most of our presentations are recorded. And we always share them on YouTube, right? And basically, we always make sure we share a disclaimer on our webinars. We call them webinars. It's part of what we call a series, the Saving Lives During COVID-19 Pandemic True Contact Tracing webinar series. So we always start with a disclaimer that it's not a platform for advice to patient. It's basically just strictly, for educational purposes, for our contact tracing specialist. So as Dr. Jack Michel rightly said, we're dividing our group into 10. So those are the 10 regions in the United States. So that's the way we're going to be dividing them. Right, and next week we're going to be having, we'll be choosing representatives of, our various, like at least one representative from the various regions to join our core leadership team. So, and those will be called leadership managers. We're still developing organizational structure. Right, and at this time, we're almost 300 plus strong, and we're growing every day, right? And so it's actually be overwhelming. The interest, everybody is really want to be part of this. And interestingly, we have volunteers from other parts of the world. We're having a lot of traffic from Pakistan, India, Canada, Dubai. So we're really going global. And like I said, we have passionate group of volunteers, and we're continuously trying to find ways to make sure we're utilizing all the skill sets within the group in a very appropriate manner. We have lawyers, we have international medical graduates. Myself, I'm an international medical graduate, but I've been working as a global health consultant for over 10 years. So we have people with extensive experience, and we're learning from each other brainstorming ideas, bouncing ideas off one another, and just our major aim is to prevent the second wave, potential second wave if it's going to happen, right? According to the CDC, we all need an army of contact tracers to help with that, and that's what we're here to do. Yeah, thank you, Dr. Mitchell. I'll pass the mic back to you.
Thank you. So the next thing we're gonna do is I'm gonna break you out into, we're gonna do like a 5-minute session where we go into different rooms. So I'm gonna have to shout out your name, and you're gonna tell me which room to assign you to. So we're gonna do a breakout room maybe for like 5 minutes, so you can get to meet each of the teams that you're interested in. Unfortunately, I'm gonna have to just do a manual read. So let's say, who wants to go into team one? Just give me your first name and your last name. We'll do one by one, I guess. Anybody?
One
at a time. Sorry. Go ahead. You know what?
Should I type in the chat? Should I type in the chat?
It's hard to follow. How about? Let me ask Musa. Where do you want to go? Adil, Musa. Oh, okay. Adil, Musa.
Hello.
No? What room do you want to be in?
1.
Okay, so I got you in 1. I'll start assigning you one by one. Akil Gupta.
1.
Okay. Alam Hamdan. Alicia Folks.
9.
Okay. Alexandra Bowles.
1, please.
Every time you change the room, I have to change the. Okay. Alex Spohn. Alex. Ali Zadeh.
Team 4.
Alina? I'm sorry, 4?
Yeah.
1 second. This is easier, I think. Alina Alvarez? Alina?
She's 4.
4, okay. Amaranth?
Team 4.
Amy Thorkmorton? Andrea? I guess, Andrea, you go to team 2, right?
Yeah, I'll stay with team 2.
Andrew Barry?
1, please.
Andrew Young? There's 2 Andrews. Andrew's iPhone?
Team 1, please.
Okay.
I'll change my name, sorry.
This is, okay, no problem. Ang?
No, team 9, please.
All right. I gotta like scroll down now. It's good. We want people in every room. I don't know how else to do this, but I think this is the best way. Ashwin? Ben Whitcoff?
1, please.
Okay.
Hello?
1 second. Bill Hun?
Team 1, please.
Bina?
Team 4.
Blake Sanders?
Team 1, please.
Ashwin, team 10. Is it working? I don't know.
Yeah, you're not going yet. I have to assign you first. Blessing?
Okay.
Blessing? Brett?
4, please.
Camilo? I guess 3, right?
I guess putting on a chat doesn't work.
Yeah.
No, it's just hard to follow for me. But unless, can you guys assign 2 or no? Or is it only me? Camilo, you in 3? The app, right?
Yeah. Wasn't it team 10?
Yeah, you know what? I'm gonna put you in team 10.
Okay.
Yeah, because you're basically dealing with that team. So, okay, Carolina de la Cruz, Charles Anderson,
All right, I'm gonna send my name in there.
Chris Johnson.
I'm just gonna
team 2, please.
We'll find some efficient way to do it next time, but I just want to try it this time. Chris Logas.
Team 1, please.
See, I could do it randomly, but it's not going to be. Danielle Lazara? Danielle? Miami? Humberto, are you on the line?
Yes.
Humberto, are you there?
Yes, no, I'm here.
Yes,
no, Humberto, the 14-year-old kid.
Oh.
Humberto. Are you there?
Yes.
Do you want to do your video? Why don't you guys just, you know what, let's do the chat thing. Send it to the chat and then let's watch Humberto's video.
What I just did.
You did your video?
Okay. Yes, I have it. I have it right here.
Yeah, watch his video while you put you on the chat group. So just text me your preferences.
How's the conference going? They're making us assign to what team do you want to be. They're what? Assign for this. What COVID team you want to be part of?
Okay, so I got a group of people together to be able to make this video. It's called the #ShowTheWorld video, and I tried to further our cause.
Everybody mute for him.
Yeah, please everybody mute for the speaker, please.
And I can't do it because you're the invite. Now, we could get a trach, and it's possible, we'll transfer to a Delta. It's possible we could.
Everybody mute, please. Mute your phones.
We don't know the event. She won't be sedated before. However, hold on. Hey, Ron,
why is Manny's calling me?
Guys, mute your phones.
All right.
Go ahead. Put the music on. That doesn't come out too good. Oh boy. We don't hear the music, Humberto. There's no music.
Oh, okay. The music. Okay, I'll restart it.
Just start it again.
Okay, so I'll. Okay, I know how to fix the problem.
Pregunta si se escucha cuando vayas a empezar.
So he's 14 years old and he put this together for us.
Okay. Okay, now I fixed it. If you don't hear anything, just say it so that I can pause it and try to restart it. So the beginning has no music. So it's around the 2-second mark where the music starts.
time when we heed a certain call, when the world must come together as one. There are people dying. Oh, when it's time to lend a hand to life, the greatest gift of all. We could go on pretending day by day that somewhere will soon make a change. We all a part of God's great big family, and the truth, you know, love is all we need.
We need your help to save lives.
Le coronavirus, on donne le sang de votre part pour sauver la vie de 3 personnes qui luttent activement contre la maladie.
المرض كوفيد-19 ملأ المستشفيات ونحتاج مساعدة كل الناس. هذا المرض ما عنده عنصرية.
Ustedes nos pueden ayudar a salvar 3 vidas, por favor.
Призовите се към нашия екип за борба с коронавируса.
Hashtag show the world.
Montrez le monde.
โชว์ให้ทุกคนอยู่ในโลกรู้ Hashtag show the world.
Hashtag enseñarle al mundo.
Und zeig die Welt.
So, what do you think?
Okay, everybody make your comments. Well, I'm still assigning you to rooms, so talk to Humberto a little bit.
Okay, so what did you think of the video?
Amazing video. Can you hear me?
Yeah, I can hear you.
Yeah, that's amazing. Thank you so much for putting that together. You know, it's a really great way of getting everyone involved and engaged and spreading the word, and it really touches people. I mean, you really get to see the other side of the virus. Thank you.
Yeah, that was so great. I'm actually I'm one of the dietetic interns for Larkin right now, and we are actually working on the Larkin social media, so the Instagram account. Would you potentially be able to send us that link so we can add it to show individuals on our Instagram? If you're okay with that, of course.
Yes, of course I'm okay with that.
Awesome.
I have the link right here. I'll copy it and put it in the chat if you want. I could email it to you, or I could just put it in the chat. There's a link.
Yeah, either way, whichever is the easiest for you.
Okay. Yeah, I just put it in the chat. It's the YouTube link.
Awesome. Thank you so much. Great video. It's amazing. I really enjoyed it. I think it's a great way to sort of reach our viewers, and I think it's very informative and it's touching as well. So awesome. Thank you for putting that together.
Yeah, I'm actually showcasing the video today on a Hispanic talk show, so that also could boost it up a bit. It's around 217 views right now. So it could be great to spread the word. I think that's like the purpose of the video, to spread the word. Yeah.
Do we have our social media team from Team 10 on the line? Are they here? Camille? We have a team that's working around the clock on doing a lot of social media stuff. I don't know if they're... Obi, are they on the line, do you think?
Yeah, I'll just try and make sure that Caron gets this video. Yeah, so we'll get it across to the team. But thank you so much for this. This is an amazing video. We really appreciate this. Yeah.
Do you want to, Obi, you want to go over maybe you go over the chat questions, and then, well, I'll do this because it's going to take me at least 5 more minutes to put you into groups. It's just, but go ahead and maybe you want to go through the chat and see.
Okay, yeah, let me go through the chat and see the questions. Give me 1 second.
While you're doing that, because I did make a note, and this is Virginia Johnson, and I'm in charge of all the volunteers, and I just want to put the offer out there as I sit and watch this, and as a layperson, it's an amazing project that you guys are involved in. So many different arms. I've learned so much today, and it's really impressive to witness. As you guys need volunteers, please reach out to me. Dr. Michelle has my email, and I will help find you the assistance that you need. There are a lot of people in our community who want to volunteer and are home waiting for an assignment. And if you can help them, give them something to do, and you especially need it, it would be a great match. So good luck to us all. Thank you.
Yeah, thank you so much for that. So I'm going through the chat. We have a couple of questions. I don't know if this is for team 1 or 2. The one, can you please explain ozone therapy? Thank you.
Is Dr. France on the line, or anybody working on ozone that can talk about it?
Yes, I'm here. I think I'm in team 4, but it's okay. I can explain in the meantime. Ozone therapy is the use of oxygen 3. Ozone is oxygen 3, and it has been a medical use for this oxygen, where in this case, you can oxygenate the blood of the patient. You take the blood of the patient in a blood bag, you mix with the gas, which is the ozone gas. That mix with the dissolve quickly into the blood, and that will generate what's called intermediate substance that will cause the benefit. I gave the literature about all the effects that has ozone when you mix the blood and then you reinfuse back to the patient, which is like that's called autohemotransfusion. And you just use 200 ml of blood, that's it, that's all what you need. And you just transfuse in, could take 40 minutes, an hour, depends. And basically one of the effects is actually to decrease the inflammatory interleukin, which is actually, I know you're talking about using some medication, some drugs for that. Actually, also one of that. The other is to improve the microcirculation, also improve the hemoglobin dissociation curve to make easier hemoglobin to release the oxygen. It have like 12 or 14 different effects, depend the way you use, how you introduce into the body. I personally use as an anti-inflammatory, injecting into joint muscles, and also has a regenerative effect when I use in musculoskeletal medicine. But for this type of procedure, what they have been having really good success in Spain and Italy is doing the blood ozonification, which is called the Mayor autohemotherapy.
Yeah, thank you so much for that insight. And we have another question. I don't know if that will be for you or someone else on the team, from Monica Moltani. And Monica is asking, do you guys have a treatment algorithm for plasma transfusion as well? Or does everyone that gets to the ICU get one? Treatment algorithm for plasma transfusion. That's Monica Maltani. Monica Maltani, yeah.
It's not part of the algorithm right now, but I think we're going to try and implement it early so that we order it within 24 hours of hospitalization.
Okay.
Yeah, we would like to basically add that to our algorithm to the point that instead of using it as a last resort option, or if we don't have any other options, rather we want to use it early on, like Patrick said. So that's something that we need to add to our protocol once we come to a consensus as to what's the best way of doing it.
Okay, well, thank you for that. And Ashwan wants to know, where can I donate my plasma? That's from Ashwan.
Yeah, I'm going to be onboarding him.
Okay.
Mm-hmm.
How do they reach you?
Oh, I gave him my number, so he's going to text me.
Oh, okay, okay.
Mm-hmm.
So Yasmin wants to know who's the team leader for Team 4.
It's Dr. George Michel.
Okay. Yeah, I think those are the questions we have for now. I can't see any other questions on that chart. That's about it.
Okay, still need a few more minutes. So if you guys want to just have a conversation while I put you into rooms, go ahead. I have to put you on mute when I do this because otherwise you hear my dog.
Yeah, so there was a team that was I think I don't know, it was Team 4 or 5, and I know they had like a lot to share about some of the therapies that we have right now. So I think there's a clinical team, so they could continue the conversation while Dr. Michael Mitchell finishes up what he's doing. So I'll take it back to the clinical team, please.
Yeah, so yeah, Patrick, I'll text you. Yeah, I think that our goal should be one of the big goals, and like I was talking to Alina about that, is to basically come up with one unified protocol between the two campuses, and that's going to require obviously help from the residents at both campuses, but also help from the attendings and the supervising attendings, the admitting attendings, and also the consulting services like infectious disease, pulmonology, to come up with one unified set of guidelines and go use that rather than one physician doing what they think should be done, another physician going with what they're more comfortable with. And that way we can actually pull a greater number of results and a bigger patient population.
Yeah, we were just trying to find out how we could do that. How could we unify in a way that both campuses are doing the same thing, and that way we can have more data when we do it.
I think a good idea would be to create a dynamic document, because I think right now the protocols are changing. When we started this in March, it was almost different. So I think it needs to be also a dynamic document where it's actively being changed every day. And I think if we just have that available to both campuses, it would be great. I don't know if we could set that up on the drive or something. An idea.
So I think Linoge asked the question, how does Xofluza got in as a possible treatment? So Xofluza, we know that it was I think FDA approved back in 2018 for influenza, and they were showing that patients who got Xofluza had a shorter duration of symptoms. And at the time, there was some concern about creating a little bit of resistance. However, we are now, there's some anecdotal evidence about its use in coronavirus. And if you look at the mechanism of action of this drug, it basically inhibits part of the viral replication, the initial part of the viral replication, essentially the capping. So we are trying to see if, if we're going to have a similar effect, similar results while using it for coronavirus patients. And I believe Dr. Jack Michel was saying that in Germany, they're using Xofluza, and they've had some good results with it. So we wanted to see for ourselves, to see if we can replicate the results.
One of the big issues I think we were having was deciding when we anticoagulate, how much do we anticoagulate. I think that's going to be said pretty clear for the residents at least.
Yes, at this point, we decide we are doing prophylactic anticoagulation on everybody that gets admitted. Once it gets admitted. In terms of full anticoagulation, we're going by the D-dimer level. Basically, anybody that has a D-dimer over 1,500 gets full anticoagulation.
All right, I'm glad you said that. I think we were using 2,000 points. So
you guys are 2,000, okay.
Anticoagulation was under 2, then we did 40 local BID.
So I believe for us, we use
population either way.
No, we
is
lower. Yeah.
Below 2, so below 2,000, we use 40 milligram BID, and if it is above 2,000, we do full dose Novalox.
No, but But that's what I'm saying. See, that you're using a different number. So I
Yes.
think we need to come up to a uniform number.
Yeah, we just have to agree on one. So. Okay.
The other question, I mean, this might be a little bit too early to ask that. Maybe Patrick can actually chime in on this one. Are we continuing anticoagulation on patients who are leaving, the ones that were, coming in with high D-dimers? Are they, either going out with anticoagulation for several days? I think one of the algorithms that Patrick sent out from UNC,
about 30 days.
Yeah, they were looking in, they had stratified patients in different groups, and for certain groups, they were doing 30 days of, I believe, Xarelto 10 milligrams daily or Eliquis 2.5 BID for 30 days and until patient is fully mobile. So is there something that, we should be doing, including in our protocol? Patrick, do you have any input on that?
I mean, just like everything, there's no data to go off of, just what other people's experiences have been. And the rate of thromboembolic disease is so high, I don't think it's hard to justify putting him on it for 30 days.
Mm-hmm.
And so far, according to the protocol we had when I was in the COVID unit, so whenever the patient is discharged, if the D-dimer is below 0.5, we just send them without any anticoagulant. And even if it is higher, we don't send them out without an anticoagulant. Maybe if it is something that we should implement, that would be great.
So I think the issue with going backwards is that a lot of the stuff that we did a week ago has already changed. So I'm not sure that's what we're doing now at this point in Palm Springs, but we really just need to unify it. And I think creating a dynamic document that allows us to just log in and see what was changed overnight from the team researching is important, because we're not doing the same thing that we did in mid-March compared to what we're doing now. It's completely different. Also an issue with steroids, stuff like that, laces to keep hypoxemia. So there's a lot of, I think creating a dynamic document that people could actually just log in and see instead of just one handout, because that's going to change. It's going to change constantly.
Yeah. The other thing, I think we need to assign maybe somebody to be able to keep track of the different patients that, who's getting what. So we can put it
We
together.
have one from each campus to be in contact with each
Right,
other.
so we can put it together and see what seems to be working better.
I have data from, I think it's 25 patients. The problem with that data extraction is that takes a lot of time for Orlando because everything is coded. But once I get the data, I can run analysis the same day. So right now I have 24 patients here and I have all the characteristics, and I can tell you that the best two predictors of lectin state from day one is the eosinophils and the neutrophil lymphocyte ratio. When those are below 0.2 for the eosinophils, they're going to stay more than 10 days. So that's to prepare, just to warn you that those markers are right there for you. And then the dimmers, they can increase because if you have someone in bed 10, 20 days, of course, everything's going to increase that way because the stasis of the blood. So I think I will consider be more aggressive with the antiviral on the plasma from the beginning. And then if the eosinophils and neutrophil ratios, they stabilize track. If they start to decrease and increase with the decrease the eosinophils, then you switch over into more anti-inflammatory. And the most, I have 3 patients here. The 3 patients that were on anti-allergic drugs, steroids and inhalants, steroidal inhalants, they were discharged. So that's our data. And in other places of the world, again, the allergic autoimmune people, they're not hitting the hospitals. They don't have even one. In Wuhan, they have 0.9% of these patients, and they made up 15% of the population. So if I get a dynamic document, I can analyze every day, but its extraction of the data is so hard that it takes time to do it that way.
So we've been doing these inflammatory markers just to determine the risk stratification on the patient. Based on, I think we're using Massachusetts General Hospital guidelines initially. Is there any data from that in regards to the D dimers and all that? Is it the same information as all?
Oh, the one I have is the one I'm following is on those CBC markers that I mentioned.
Yeah. Okay.
And then I'm seeing this all over the world, basically Italy, Korean. I hung up. I was in a meeting with a Korean group, and they're seeing this. It's 85% of patients that they coming to the hospital with 0.2% eosinophils or lower, they get severe. That's a lot of people. So that's the warning sign. You know how to treat it. That's the other part of the story. And then males, that the same models are, you know, all over the world. Males, here we have like 20 from the 26 patients, 22 are male, and most likely they're going to be over 60, 65. So in terms of risk factors, all over the world is starting to take exactly the same trend to everyone.
Was there anything in the type of blood, ABO, compatibility? I heard O was more resistant.
On the models that I have seen, they are they correlate or they correspond to the actual percentage of the population. So they say more A's because you have more A's in the population. It's not, I mean, when the trend, if you have, for instance, if you have 10% of the population of that country, it's like, for example, Italy, more of the high percent of people in Italy is older than 60. So they have a higher mortality rate because of that, okay? So it's not coincidence, that it's explained. But then when you have, let's say, if you have a country like Germany or like Israel, that they have a similar demographic, but they have less mortality, what they are doing. So they isolated all the old people from the beginning. They are basically isolated in homes. So those are the things that I'm trying to look into the data or whatever they can collect or send to me.
Somebody asked about remdesivir.
Yeah, so I was asking if we're able to get that.
So we talked to Gilead about it, and they're only they have not designated us yet, so we can't get it as of now.
Okay. Yeah, we have another question. Give me 1 second. Let me read it out. I think it's from Ashwin. So Ashwin was asking, like, for plasma transfusion, would one specify COVID IgG plasma as a nursing order? Just wondering about how the new changes will be implemented and what the practical takeaway is with regards to implementation.
If I've been actually, this is Vanessa speaking, I've been actually doing the plasma transfusion, helping the ICU team. If you want to do plasma transfusion, you're just going to put the fresh frozen plasma in the order section, and then you're going to input the following instructions, which I've shared with the lab directors, Millie, and with Onel. You would just put infuse 200 milliliters of convalescent plasma in the instructions, and that should get the ball rolling. With respect to the COVID IgG, I don't think we have officially yet the antibody testing yet.
Okay. Yeah, thank you, Vanessa. I think that's the other question from Pamela.
So we do. So there's a change in that. I mean, we do have the antibody testing. Actually, it's available now. We just found out from the lab. I think the question is, what's the use of it when we have people that are positive, that we have that we know are COVID positive? As far as the plasma transfusion, I'm not so sure that it makes sense to go after antibody positive people when we already have a big pool of people that we know are positive. So it's more of a question. It's more of a question of what's the use of it really? Is it more for someone to feel better, to see if they got it or didn't get it? More epidemiological, implications, but maybe not so much practical. But let's open the conversation though.
It's more epidemiological, but interestingly, there's a study in Santa Clara County, and they found 85 times more people with antibodies than confirmed cases. So that talks about infectivity and the way it's spreading around. So perhaps we have had this for a while now. It was right there.
Yeah, that's pretty obvious. I mean, it's clearly everywhere.
Mm-hmm.
I just so you guys know, we were asked this past week. A courageous nursing home decided to test their employees, and basically half of their employees came back positive, and half of their patients came back positive. We just had a jail system. Basically, everybody was positive. So, I mean, this thing is clearly everywhere. There's no question. I think the wave is going to be good. Go ahead.
I wanted to, one of the reasons why I also was asking about the antibody levels, thinking about for how long does it confer immunity. It's more of a research type of thing than a practical aspect of it, but just
so the answer is we don't know. It's a new virus. We don't have any reason to believe that there's no immunity from it. Obviously, that's what happens usually with viruses. You get immune once you get the disease. So there's no reason to believe that you don't become. But the problem is also the reliability of the testing is, what does it mean if you don't have a high IgG? Does it mean that, that's the question. It's just, I'm not so sure that other than for epidemiologic purposes to know, okay, this percentage of population may have got the disease already and recovered from it. I'm not sure that I would even be seeking blood from people when we have such a pool of people that we know are positive and now are negative, and we could also do antibody testing on those people. So anyway, that's kind of my feeling, but you guys are free to chime in. So I have assigned a lot of people. There's some people that are still unassigned. So let me just go real quick. Jenny, what room do you want to be in? Jalesi? Virginia, any room preference?
No, I actually would like to bounce around so I can hear from everybody.
Okay, okay, so I'll move you later then. Vanessa?
Okay.
I would like, sorry,
go ahead, Vanessa.
I'm in team 2, but would also like to be in team 4. But for this, yeah, I mean.
You want to be in 2 and 4?
Both.
Let me put you in 2. I can only put you in 1 room. But,
okay, for now, just put me for 2.
So Vanessa.
Thank you.
This is so hard to do. Okay, tell me any room you want. Tasha? Tariq?
Yeah, I'll go for, I want 2 or 4, but if it's only 1, I'll go for 2.
Is that Tariq? Which one you want?
I'm already in team 4.
You're in 4? Okay, I'll put you in 4. Oh.
So quick question for Dr. Franks. So we have a quick question from you from Bina. So Dr. Franks, are you still there?
Yes, I'm here.
Okay, so Bina is asking, am I able to message you or email you to ask you more about what to do with the ozone therapy? I want to make a written document. So
yes,
Bina wants a written document on ozone therapy.
I can put my email, but John Dean, I forward him the protocol and also a document that is I would say the justification on the mechanism of action of why ozone therapy, with all the literature backing up all these studies. So I think probably Dr. Michel also has that one. And he had the protocol, and John Dean who is working. Even I also forward Alina the informed consent that we need the patient to sign in order to do this, which will be considered like a alternative medicine. So yeah, I have all that information.
Thank you so much, Dr. Franks. Yes, John Dean said he's equally working on it, and Bina says thank you so much. Yeah. So if you could put the email on the chat so that Bina could see it, that way she'll follow up with you directly.
Sure.
Awesome,
okay.
Thanks.
Ala Hamdan, what room are you in?
Team 4, please.
Alex iPhone. Charles Anderson. Antonio Gordon. Elizabeth Saka. Fariz. I think I'll just
Yes,
quick.
team 9, please. Elizabeth Zaka.
Elizabeth, team 9. Okay,
Thank you.
I'll stay with my team, team 7.
Oh, wait a second. I already put you in one.
Oh.
Let me hold a second. So let me get Elizabeth in here. Okay, I got most of you in. Fraud, what room do you want to be in? And you want to be in the plasma room?
Yes, the plasma room, please.
Okay, so the purpose of this part of it is just kind of, when you go into these rooms, just, I'm going to give you like 6-7 minutes just to talk to each other. If there's new people there, it may be just the same people you already know. I'm just going to let you start doing that. And I'm just going to stay with the people that haven't had a assigned room, and I'll send them to those rooms, okay? So I'm opening the rooms now. You're going to get a 60-second notice when I'm about to close them so that you can wrap up your conversation. So anybody that's assigned is going now.
Dr.
Okay, so
Michelle, I went to the wrong room, team 10.
Oh, this is Elizabeth?
Yes, please. If you can, like, assign me to team 9. I found myself in team 10.
You're in team what?
I found myself now in team 10, but I want to assign to team 9, if you can, please.
Let me move you to, which room you want?
9, please.
Okay, there you go. You should
Thank
be going
you.
now. No problem.
So
Dr.
anybody
Michelle,
that's
unassigned that wants to be.
I did not get assigned to a room, so I should be in 10.
Who's this?
John Van Keppel.
John, let me find you. Are you identified by your phone number here? No, is it the same iPhone?
It's iPhone, yeah.
Okay, there you go. So which one again?
Team 10. Yeah, I lost my signal in my house, so I had to go to my iPhone.
I'm sending you to team 10 right now.
Thank you.
You got it.
Okay, Dr. Michelle, this is Manib Ilyas. Could you assign me to team 1, please?
Malin. Okay, got it.
Thank you so much.
You go. Anybody else that's left on the call that wants to
Dr.
join?
Michelle, I think group 9, please.
Virginia.
Yvette.
Oh, Yvette. Okay, wait.
It shows Yalesi on the profile.
Oh, how do you spell Yalesi?
It's Yvette with a Y and then Alessi. The picture shows Yalesi. Yalessi.
Okay, got it. What room did you say?
9, please.
All right. Anybody else wants to move to a room?
Yeah, Dr. Michelle, please assign me to room 4.
Okay. Dr. Michelle, this is John again. I didn't get moved over.
John.
Yes, me too, Dr. Michelle. Elizabeth, I'm still
That's
here.
Weird. Okay, let me see. I think maybe it's my thing here. I can't find you on my list. Did you get like a notice to move over or no?
Me as a
No.
John? No, I did not. I did not.
Me too.
Strange. So John, what room did you say you were in?
10. I should be in 10.
Yeah, I have you there, but it says not joined. Maybe you need to press something?
Okay, I'm looking to see if there's something that tells me to move.
Yeah, I see you as Team 7, but it says not joined. So something happened. Elizabeth, same thing with you. You're at which room? Yeah, 9, right? Yeah, it says you haven't joined. I don't know why. Oh, no, Elizabeth's gone. Okay. So John, let me look at you. See, you should have received something that allowed you to press on that room.
No, I didn't receive anything.
Let me move you into another room and then I'll take you back out.
Thank you.
This is Gene. Do we have a room 11 for the research team?
No, we have it on 4. You want to go to 4?
No, maybe, can I do 1?
Okay, so it's Gene, with a G?
Gene Schwartz, yeah.
I can't find you here.
In small letters.
Let me keep looking.
Yeah, it says GS, blue icon, Gene Schwartz.
GS?
Yeah.
Oh, no, Gene Schwartz, right?
Yeah.
Gene Schwartz?
Yeah. Yep.
Did you say Gene Schwartz?
Yes, correct. Yes.
I can't hear you.
Yes.
What room?
Yeah, Gene, room 1.
What room, Gene?
1.
Okay, you're going. Yep. Anybody else?
Does anybody need to go to team 2 right now? Just because we're onboarding some people right now. And if anybody's left over from here, I can just bring them over.
Yes, please.
Anybody
Team 2 for Fitzig.
Fitzig, let me look.
Anyone for team 2?
Hold on one second. I'm trying to find Fitzig. Are you logged in under another name?
Jeremy Fitzig.
Oh, Jeremy. Okay, got you. Team 2, right? Yeah, you're going. Okay, anybody else want to move?
Me, Dr. Michelle, I was not assigned yet.
Okay, I'm sorry. Laura, where do you want to go?
8. Team 8? Okay. I was in team 8. Yeah, I'm the leading.
Moving you to 8. Perfect.
Yeah. Thank you.
I still didn't get assigned to anything, Dr. Michelle.
Oh my God.
Yeah, we're not assigned either.
This is weird. I don't know how to do this anymore. Okay, let me start with the first person that talked. I'm sorry. Give me their name again.
This is nothing.
It says Dr. F2F. Who's that?
That's Dr. George Michel.
You guys want to be moved to a room?
Yeah, we want to be room 4. We're group 4.
All right. I just moved you. You have to press something when I do.
Dr. Michelle, please add me to team 4.
Who's this?
Lashathan Banks.
Okay. Okay.
Thank you.
Who's left? John?
Ed.
You still here?
Pamela.
Okay. John, did you get moved? Okay,
Jonathan Chan did not get moved?
Jonathan Chan. Hold on. Pamela, where are you going to go?
Room 9, please. Team 9.
Okay. I just should be pressing something. Anybody left that wants to move over that I haven't moved?
Hello, Dr. Michelle.
One, please.
Say that. Who's this?
Harry, room 4, please. Team 4, please.
Okay, there you go.
Thank you, sir.
Anybody else?
Yeah. Hello, Dr. Michelle. This is Marcos. Is there any room 11?
No, it's 4. So I'm going to put you in 4.
Okay, thank you very much.
Hi, Dr. Michelle. I was going to see if you get me into room 4.
Who's this?
Raul Fernandez.
Okay. Anybody else?
Dr. Michelle, this is Nicholas Applers. Can you transfer me to team 1, please?
Okay.
Thank you.
Welcome.
Dr. Michelle, Emmanuel McDonald, can you transfer me to room 4, please?
Emmanuel. I don't see you. You sure you didn't get a notice to move? No?
I don't believe so.
Yeah, I don't have you in the room. Let me see if... That's weird. Let me see if you...
Actually, I got it. I'm going now.
Yeah. Just go ahead and press it. Yeah. Right. Anybody left here that wants to go to a room?
I'm still here. John Van Keppel's still here.
John, okay, I got you. Room what?
10.
10, okay, here you go. Try now.
Okay,
see
there it is.
Sorry. Anybody else?
This is Ralph Tawil. Can I get room 4, please?
Okay. Anybody else?
Jonathan Chan, room 4.
Okay.
Thank you.
You're welcome. Anybody else? That sounds like everybody else wants to stay in this room. All right. It's 18 of us. Everybody else.
Hey, Doug, could you transfer me over to team 2? This is Monica Multani.
Okay, Monica.
I think I'm the last one.
Yeah, got you. Anybody else want to move?
Pretty impressive. It's Virginia. Yeah, I don't think I can bounce around because so I'll just wait because I have only talked to one of the team heads. So as I talk to them in the next couple of days or whenever, I'll get the update on what happened with all of this. But this really, this really puts the whole thing into perspective. And
that's great too. That's great to hear.
Yeah, really interesting to see, and I appreciate that. So yeah, I won't go to a room. I'll just listen and see what happens.
Sounds good.
Yeah.
Sounds good. I'm going to give them a little bit of time to talk because it's only 21. There are 80 of them over there. So.
And are all these are these all hospital employees or volunteers? Or who are
the residents are all, the residents are all hospital employees. The ones that we're talking about treatment.
Mm-hmm.
Yeah. So they're all hospital employees, but we have a lot of volunteers, obviously, too.
On this call.
Yeah, we have like Obi is a volunteer or from Team 10. He's actually in, I think he's in Virginia or, and then Damashi, the one that was talking about the monitoring, she's in California. Right. So yeah, we got people from all over.
Actually, I sent you an email because her email came back to me, and so I don't think I have the correct email. And I know that
she has to give you her personal, because some reason there's something with her other email that keeps bouncing for some reason. I don't know why. We had the same issue with my email. Yeah, we'll ask her when she comes back.
Okay, great.
Seems like it worked pretty good.
Ooh, that was quite a little task there to have to
manually do that. No, you know what the problem is that it's this computer. Every time I touch something, everything moves.
It would be nice if there's just like a sign-up sheet that everybody could just click onto their team and move to it.
I have to call Zoom and see if there's any way that you could pre-assign yourself, because it can do it 2 ways. You could just randomly do it, and it just breaks you up into whatever room it decides.
Right.
But for manual, it's like you really have to go one by one.
And it's not like you have 10 people to do it with. How many did you just do? 110 or something?
Yeah, I just moved like 100 people over. But another thing they could do is probably like just change their name on the Zoom and just call put team, but maybe put the number of the room before their name, and that way next time I can just go boom, boom, boom. I'm gonna ask them to do that because man, this was hard.
Yeah, well, you certainly can't do it every time. And what because now with all of this happening right now, how often is this group meeting? I saw that you had monthly, but it seems like that's not often enough now. Yeah,
I want to see just how they, if maybe every 2 weeks. I'm thinking because a lot of like the team 4 meets every Monday, By the way, you're invited to join it. It's just the same number every time. So they just talk about treatment. So all you're gonna hear is that's why when they went into that rabbit hole and they started like arguing about treatment, I was like, wait, this is not for this team.
By the same token, I just want to keep reminding them that if they need volunteers, we can get them to, you know, because I don't understand, you're right, 90% of what's being said, but it's fascinating that it's even happening. So go ahead. So that team meets every Monday.
Every Monday, and that's all they talk about is treatment options. And so I've been trying to push them into things like ozone because, you know, unfortunately they say, well, there's nothing published on anything. I said, there's nothing published on anything. So
it's too new.
Why not try it? You know. And so I don't know if you saw Dr. Franz Richter. He's actually a board certified PM&R doctor, trained here. So he's not like a witch, you know, doctor or anything like that. And he's used it. It's been very effective. And so every time he comes to talk about it, everybody starts like attacking him. And I'm like, no, you don't understand. We don't know how to treat this virus. Right. We should keep an open mind.
Oh my gosh.
And so, it's going to kill the patient. It's going to cause a pulmonary embolus. I'm like, no, he's done it. It's safe. So tomorrow, actually, he's going to go do it with a nurse at the hospital because they've been resisting me for 2 weeks. And I'm like, you need to try it. But anyway, it's funny when you have something that has no cure. Why wouldn't you try everything? You know.
Oh gosh, you sound like right. But do you see a benefit in getting these teams all together like this on a regular basis?
I do, because what I've seen is like a lot of our residents are very involved in the medical stuff. Like they want well, we have dental residents that are doing, you know, some of the calls for plasma donations. But other than that, they all like want to just do their field. And I kind of want to give them I want to give them like an introduction to the whole picture, because sometimes they don't see the whole picture. Right. Like the plasma donation team is working really hard. So they're working so hard that now we have a problem. We have too much plasma. And so I said, well, we need to work with the patients and their family members and see how we can get through these crazy hospital administrators that don't seem to, you know, like I was talking to the Mr. Palmetto over the weekend, and she's telling me, I have a contract with One Blood, I could get sued. I said, look, you tell the jury that this guy was going to die and that you weren't going to follow a contract. And I don't think they're going to find you guilty.
Yeah, all bets are off right now. Yeah, because the jury's going through it too, and probably has had a family member.
The jury that if I followed this contract, this person would have died.
Exactly. But let me ask you, because I talked to Laura yesterday, and she said that they don't have enough to do with the call center. That
no,
they
because
that they don't need any volunteers, and that they've had a really slow week.
Yeah, it's waxing and waning because it's all PSAs. So sometimes we get the stations to give them, and sometimes we don't. Okay. So it's like up and down. Like a couple of days last week, they had 50 calls, and then it just dies down to like 4 or 5. But they're getting like 5-6 calls a day. But I think it's amazing because they're going out of that pool. They're not working with 1,000 people that are positive from our drive-through. They're actually on the radio telling people, you may have gotten tested at Baptist or at some urgent care somewhere, and you can actually donate with us. Somebody's texting me. So that's the neat thing about it. I just want to I think we need a team to just concentrate on where does this plasma go? You know what I mean? Like, because we keep seeing people on TV saying, oh, my relative is dying in ICU. And then somehow we can't get the plasma to them. I don't, you know, it's just.
Yeah, because you said you have 25 units that are just sitting there that nobody needs, huh?
32.
And what's the shelf life on those? How long do those last? What?
1 year. The problem is the blood bank is a business, you know, even though they're not for profit. Right. So they're starting to tell me, wait, you said that you needed this plasma, but we're not getting requests. And every time a hospital calls us, they're saying they have a contract with One Blood. So can we sell it to research? I'm like, no, wait, you know.
And One Blood won't buy it from you.
No, they've got their own. That was funny. You know what happened with that? So we gave them like 6 or 7 donations. And like Patrick said, it went to some repository, quote unquote, somewhere. And it just disappeared. So we had 4 people in ventilators that needed it, and we only got it for 1. So then when I talked to this other blood bank, they're like, no, it doesn't go to a repository. They're selling it to the highest bidder. That's what's going on. I'm like, donors don't know that their blood is going to some research and somebody's making money. That they wouldn't be donating if they knew that.
Right.
We're telling them they're saving lives, and they're not really saving lives. So we have that problem right now that we need to kind of like find a way to get through to these hospitals and say, look, because the one blood people are just like, it's all corporate. It's all corporate. It was funny because they had this big show. They brought cameras, and they said, you can't call the media. So I said, wait, like I've got volunteers doing this. They want to get media involved so they can get recognized. And they said, no, because it's not fair because of the privacy of the donors. I said, what about your cameras? They have different privacy rules with you. You're going to put it online. But it's just like, I don't know.
I think the rules are just different now. I think that everybody's going to be looking at a lot of this differently. And you're right. When it gets before a jury in 4 or 5 years, if that's what ends up happening, and all of those jurors have gone through this, they're going to say, you know what? Now they understand state of the art. Now they understand, putting yourself in the shoes of something that's happening at the time it's happening.
I was telling somebody today, like, where are the PI lawyers when you need them? Because really, they should be on TV saying, if your relative's not getting plasma, call me.
Well, see, and I'm seeing the ads because I do personal injury stuff, but I do defense, and I've seen the ads with, are you being forced to work? They're all, or have you?
How about is your family member in the hospital not getting plasma?
Exactly. You know what?
Because we knew what's going to happen. They're going to run for the plasma.
Yeah, it's true. Maybe that should be our angle.
I was about to call somebody today. I said, can you get me to the PI lawyers? So
right.
At least put an ad out there and scare the shit out of these people, because that's the only thing that works.
It's true.
Better liability.
It's true. Although everybody then just starts thinking money.
Yeah, that's true. You can't stop that train.
No. Well, especially when they're broke right now.
Yeah.
Trial lawyers will never go out of business because when it's recessed, people look for whatever reason to get money.
Yeah, it's true. It's true. You think we should bring them back in, or?
It's up to you. I don't know how they're doing. How do we know?
Let me join and go. Let me go there and see, and then.
Well, I think 10 is the biggest. You might jump into 10.
Yeah, let's see how they're doing.
Yeah.
I'll be right back.
Okay.
Actually, I'm still here, but I went through the other room, so.
Well, does this chat then only chat with this group, or does it go into the room chats? They're separate chats, right?
They're separate chat rooms, yeah. I can't hear them, but let me see if I can turn on my audio. It's gonna. Let me turn off this.
Hi, Laura. Nice talking to you yesterday. Your sound.
Okay, here we are. How are you, Virginia?
Yeah.
Nice to meet you.
It's nice to see your face. Thank you for talking to me yesterday.
Me too. Thank you too. Thank you. So, are you okay with me? Do you need something else from me?
I don't think so. I think we had a good call yesterday, and we're finishing up what we're doing. And it's like I told you yesterday, we're just gonna assign people who wanted to work at the call center, and hopefully you'll have enough to keep them busy.
Thank you so much.
Okay,
we keep in touch. Yes, today someone else joined us. So I already spoke to her, and we have one more volunteer in our team.
Excellent.
Thank you so much.
No, my pleasure. Thank you.
Thank you. Any questions or anything you need, you have my number.
And vice versa.
Thank you so much. Have a good day. Thank you.
You too.
Just checking on the rooms.
Is this the first time you've broken everybody into rooms?
I did it before with a smaller group. This is the first time it's such a big group.
And is anybody at the hospital, or are all these people in their homes?
Half are at the hospital, half in their homes.
Okay. Yeah, I saw a few that looked like they were obviously in hospital garb. Okay.
Let me see what's going on in the room too. Anybody else in this room, in this main room, that want to say anything?
Website, you can go in. Let me find it so I can just send it to you. Or I can just pull it up here actually.
Yeah, room 2 is at work. She's doing it. She's sharing her screen and everything. So I'm gonna see.
Oh my gosh, you must be so proud of this participation and then this enthusiasm and this dedication of all these people.
It's amazing.
Yeah, it's very inspirational.
It is. It is. It's kind of something happens and then I get encouraged to do more. I'm like, oh wait, I can do this. I can do that.
I can see that. Well, I'm hoping that you're going to get to a point in the not too distant future where you feel comfortable with the arms out there being controlled by the people out there, and that you won't have to be up at 4 o'clock in the morning and going to sleep at 11 o'clock at night.
That's a good point. Anybody in this room? Oh, I'm muted. So,
Dr. Mitchell, do you need something else from me?
I know I'm actually great. Thank you so much. Appreciate
Thank
it.
you. Thank you
Carol?
so much.
Is she on the call?
She's okay. She's good. Yes, she has been lately busy with her job, but she's still helping us. Yes.
That's great. That's wonderful.
Okay.
Do you need more volunteers? How are you doing?
No, we're doing good. I coordinated for Virginia already, and we're doing good right now. And if we need someone else, I will keep in touch with her. Yes.
Great. Sorry. Sorry about that. Let's see.
Is there going to be another joint meeting after these rooms close?
Yeah, I'm going to bring them all in real quick just to say thank you. And I don't want to interrupt them in the middle of a presentation.
Right.
Like they're putting stuff on the screen.
Okay, but you don't need me anymore, right? I've got a call with Obi at 5. He'll be done by then on the corporate stuff that we'll talk about. But if you don't need me, I'm going to sign off, and because it sounds like you're just going to do a closing thing, and I don't know how long this is going to last, and you're kind of monitoring it from there.
We're good. Thank you.
Okay, so we'll talk soon. Thank you.
So for instance, if they
want to leave, Dr. Mitchell,
the saturation
thank you so
level,
much.
Thank you so much.
And
thank you.
Chest X-ray is positive. So we assign that, you can say severe 1, severe 2, or severe 3. Then
Anybody in this room that wants to go anywhere?
Yeah, Glenn, room 4. Sorry, I got kicked off a bunch of times.
Oh my God, this is like, where do you want to go?
Room 4. Glenn, room 4.
Anybody else? Anybody here okay? Oh boy. Hello. So I'm trying to.
Not sure if I got kicked out.
I need to keep my phone muted because for some reason it's like repeating everywhere, but everybody's back. Did you all have a good meeting?
Yes.
Any questions, comments? Sorry about the echo.
I have a question. Sorry. I didn't get to ask in the small group meeting, but what is the protocol for introducing a new drug, say earlier on in a not algorithm, but in a treatment plan? Like I know that we've established, mild, moderate, severe. Well, how does it work if we want to change it up? How does that happen?
But let me answer. Sorry. The thing is that we look at the mechanism of action. The virus, we want to stop the replication at the beginning. As early we start the replication, we stop the replication. We hypothesize that it's going to stop the progression of the viral damage to the body. So that's the reason some countries are using oseltamivir. We are starting using the sofluxa because they're going to stop with one dose the replication of the virus, specifically at the level of RNA replication capping. The other thing that has been established for some trials that the plaquenil, because of the alkalinization of the genoma, the virus is going to be able to replicate. So that's also the plasma that we're trying to implement is with the same goal to stop the replication. But then there is a phase when the virus starts replicating, and we have to treat other symptoms and other issues. And once the virus activates the cytokine cascade, that's another disease. That's a complicated disease with the interleukin, as it's going to damage and produce trouble to the liver, to the intestine. It's going to produce to the brain. So that's a more complicated situation. So we want to keep treating the much amount of people, that 80–90% of the people, that is not going to get complicated, and we want to stop that. So that's the reason to do a trial with medication that doesn't have important side effects, and it is very unlikely that they're going to do some improvement for these patients. So that's where we're going to start the solution. I don't know if this answers your question.
Okay, can everybody hear me?
Mm-hmm.
All right, so any other questions, comments? I don't want to take so much of your Friday. I hope we had a great meeting. So this one we're going to repeat. We're thinking once a month. It might be sooner. What do you guys think? Actually, I wish I could do a poll and ask you if you thought it. Actually, you know what? I have a poll for. We still have residents on the call, right?
Yes.
Yes.
Sandy, are you on the call? and Catherine. So I'm gonna just, before we close, I want to give you this poll on some questions about different things about the hospital. So I don't know if you, let me know if you can see the poll. This is only for the residents. So just try to answer the questions, and it's about personal protective equipment. It's about whether you feel that you're safe, whether it's at our hospital or elsewhere. It's 6 questions. Only for the residents.
So how do you move to the next question if you've been to, if you've never been to any of those hospitals in question 2?
Yeah, for question 2, can you put like part C, not applicable if you haven't been there?
Yeah, fortunately I can't. I can't change it now. This is my experiment of playing with this thing. I'm just thinking it's a good way to kind of get a little pulse.
You want residents from other hospitals also too?
Well, we want to. I kind of want to get the pulse at Larkin more or less, because I want to kind of share it with the administrative team.
Okay.
To just see if, because perceptions are big for us as far as, you know, whether people think things are working or not working. I want to kind of like get, Sandy, are you on the call, or Catherine? I think someone may have had to drop off.
Dr. Michel, just to clarify, the last question, it says if we've been exposed to COVID-19 patients, is that without protective gear then, or with?
Right. If you feel you have significant exposure without protective gear, would you agree to have be treated empirically or not?
Got it. Thank you.
So far we have 32% responses. So I'm assuming that, let me know if you're a resident and you haven't responded. So we only have like 30 responses from the residents. Are you able to see the results or no?
No, you have to post them.
Yeah, I will in a second. As soon as, so we got 31 people so far responded.
And this is completely anonymous for Zoom.
Oh, by the way, yeah, I should have said that at the beginning. We have no way to know how you posted, right?
Yeah, there's no way to know or track it, so feel comfortable.
By the way, if you think of other questions that could be useful, let us know. Let me know, because I could structure it so that it's useful. So far we have 40 out of 87. I assume that the rest are not, well, okay, 41, 42, 43. So the numbers are getting a little bit better, so that's why I'm giving it more time. I'm just kidding. Let me know if you're a Larkin resident and you have not responded. Anybody else missing? I got 45. Anybody hasn't responded? All right, should I post? Yeah, Pamela, it was for residents that have started working already, yeah. Okay, so I'm gonna post, I'm gonna end it, unless you tell me you haven't done it yet. And I'm sharing the results. So can you see the results? Can everybody see or no?
Yes, I can see it.
So basically 36% felt that there was enough PPE and 64% felt that there wasn't. That's typical across all teaching hospitals. So, but I was interested in seeing what the number was. As far as out rotations in other hospitals, actually you feel there's less PPE or they need more PPE. And then you see the one about what we could be doing to ensure your safety. You feel there's more stuff that could be done, but it seems like most of that stuff is more PPE from what the multiple choice provides. But then there's 60% are saying there should be testing of every employee and every resident. And about 36% say that we should have more training. So these are things I'm going to share with the administrators, of course. The overwhelming majority wants to be treated if they're symptomatic, and the majority wants to be treated prophylactically if they get exposed. So those are things that, that we all need to, any surprises? Any comments? You guys are very quiet.
I'm somewhat surprised by the PPE because in the COVID unit we did great because we do have a lot of PPE, all the material that we needed. We have that. I don't know for other people, but I feel that we did have proper equipment.
Yeah, I think every resident, at least in Palm Springs, has N95 mask, and we do have available. Just check.
Yeah, we do have available.
So Fraud, you're at Palm Springs or South Miami?
Palm Springs. I was at Palm Springs.
Anybody from South Miami?
Is some of the response?
At South Miami, we're also getting, I mean, they've prepared these PPE packs that we sign out every morning, especially to residents who are going to see COVID positives, or, you know, if anybody is going to admit them or seeing them in the ED. And I think so far Mercedes has done a great job, you know, getting us the equipment that we need and, you know, trying to get us, you know, N95 masks and the gowns and everything. So, you know, while we're always gonna feel like, you know, yeah, we need more. I think that overall, I feel that, you know, we've been fairly well protected, and, you know, we haven't really had any issues where we're seeing people without protection. So that's a good thing. Yeah.
Okay, and then the part about that being able to do more, like what does anybody, I mean, want to elaborate on like what ideas do you have as to what more could be done to what more could we do to ensure your safety? Anything that we're not doing right now?
I think one of the issues that we're having at Larkin South is, and I think that more comes down to communication between the physicians and the nurses, is sometimes, you know, there's a little bit of a confusion as to patient comes in, they're not tested immediately. And then, you know, later down the line, like a day later or even a couple of hours later, we see that, oh, you know, maybe they should get tested. Then there's a question, you know, and then sometimes they're not put on isolation. So staff might be going in and out, not knowing that this patient, you know, is now somebody under investigation. I had another example where my patient who we were retesting because we were suspicious about the negative result that he got was moved to a room and the door was left open, you know, all night and no signs or anything. And, you know, so that's something that I think we should emphasize to have better communication between different staff to make sure that, you know, because, you know, no matter what we do, we know that we're gonna, you know, it's gonna be exposure, it's gonna be, you know, it's in the air, it's everywhere. So, you know, it's just these little things that we can do to reduce how much we get exposed, you know. So that's what I think I noticed.
Yeah, the other thing is a lot of the COVID positive patients are intermixing with the, you know, non-COVID positive ICU patients. You know, we try to keep the PACU clean, but, you know, there's overflow. So, you know, we're mixing the COVIDs with the non-COVIDs. And
any ideas on how we can have a workaround with that, or?
That's
like how about the
know?
endoscopy area? Can the endoscopy area be used, or is that possible? Or
I think they're still using the endoscopy suite for GI.
Wait,
so
for what?
I'm not 100% sure though.
For what? I mean, at Springs, the endoscopy suites in GI have been transformed into potential overflow for COVID patients. It's not there yet, but they're negative pressure to begin with. So once it becomes overflow, I mean, we're already doing our cases over in OR4 if needed. We do like a couple a week.
How about South Miami?
That I don't know. I think they're still using their endoscopy room because I don't think that room's negative
Yeah,
pressure.
we're still South Miami. We're still getting some, like EGDs and colonoscopies on, emergency IVs and all that. So they're still using it.
So is Mercedes on the line, or she probably dropped off? I'll bring it up to Mercedes, and maybe the Chiefs can have a talk with her.
Yeah, I'm gonna head over to her office right now and talk to her. So.
Yeah, are you able to get these poll results and show her, or no? I don't know how to do that. I'm new to this thing. I don't even know how I did the poll.
You could show them again, show the polls again, and I could take screenshots and send it over to John.
Yeah, I think it
them.
has to be screenshot.
Oh, it says stop share
I could
results.
screenshot
Okay.
it. If you share it, I'll screenshot it.
Okay, go ahead. You got the first one?
I'm not seeing them yet. Are you guys seeing them?
Oh, share results. Here you go.
Oh, there we go.
That work? And then you can scroll down, right?
Yeah.
Okay. Yeah, just tell them that I did this poll and that I just kind of want to
Perfect.
go over
I
that
got
a
'em
little
for
bit
you.
as far as what the communication issues. It sounds like it's an issue that we need to work around, right?
For sure. I think, everything's getting miscommunicated. Not some people aren't saying things to other people, but
Okay, so let's get that work. Yeah. Any
and also, I have another suggestion. I don't know how we can go around that. Is when a third patient who came in from nursing homes and they have 2 previous negative COVID, and yet when they show up in the ER, there is a suspicion for COVID, and these patients are being sent to the COVID unit on the floor, and pending COVID result. And when we did the retesting, it came back negative. So this is somewhat a situation where you have nurses that are caring for patients that have high suspicion for COVID or who are COVID positive, and they're interacting with patient with
so that's the thing, like we made the COVID team especially so we don't intermix, seeing clean patients from the COVID patients, but it hasn't worked very well. Even the residents are mixing.
Like, if we can stratify like level 1, level 2, if the suspicion is highly unlikely for COVID, given they have 2 previous negative COVID, it wouldn't be, like too good to send someone like this on a COVID unit where they're gonna actually be exposed to COVID, and it's
Let me. You know what? I should probably get Mercedes to log back in real quick. Hold on. Because I like to get these things resolved. Now, I have to tell you sadly that I think you're not going to have that problem in the next 3 weeks, because I think everybody's going to be COVID, but that's just my opinion.
Yeah, we tried to keep all the COVIDs on the 3rd floor, but now it's like the entire hospital at South Miami.
It's going to be that way. I think it's just a matter of time. I think in a month, everybody's going to be COVID.
Yeah, we have some positives in the second.
Can you join the meeting right now? Again, there's a second. No, it's the same. It's the same meeting. Just join the same, because we're having some discussions about things that we can fix. Oh, okay, thanks. Okay, so I'm only going to ask Mercedes, right? I shouldn't get Palm Springs. It seems like Palm Springs has more communication, right?
Yeah, I think so.
Okay.
For the patients over there, any staff, including the residents, they're supposed to change every time they see a new COVID patient. They're being isolated in individual rooms.
Okay, so I'm not going to bring Palm Springs into the mix. I think we're just going to talk about South Miami now, as soon as Mercedes joins.
I think just the capacity of the hospital is, we have to work with what we're given. The hospital it's small. The ER is really tiny.
Yeah.
I was trying to, make overflow, like the non-COVID patients and the main ER as the respiratory patients, But it's hard because there's only 8 beds in the main ER and 3 beds in the overflow. we were thinking about utilizing the tent, but I don't know.
I was gonna ask, yeah.
You utilizing the tent to put patients in there?
There's a tent outside Larkin, Maine, in the parking area outside of the emergency.
Yeah, but that's not meant for patients, is it?
I don't know what's being used for.
I don't know what's in there.
Yeah, I don't know what's in there.
No, that's supposed to be like overflow or some crazy. I don't think you put patients in there. Hey, oh, Sandy joining. Okay. Hello. Hey, Sandy. Are you a Mercedes? No, maybe she's not. Hey, Sandy. Okay. Can you hear us?
Barely. No,
okay, so we're talking about, so we did a little poll.
You guys doing okay, or?
So Sandy, Mercedes, can you hear me?
Yes.
So we just did a little poll, so these are the results. Can you read them?
Yes.
So, I mean, look, the issue with PPE, that's kind of across the board. I've talked to every DIO in the country, and every single teaching hospital feels that they don't have enough PPE. But I think the main issue that we're talking about here, obviously you see that other hospitals seem to be worse. But the issue we're talking about here is more like communication. So I'm going to let John then talk about that. What's the issue with communication, John?
Well, I mean, just get our residents to know what they're supposed to be doing. I think I have to work a little harder on that, just because I do have direct communication with a lot of the residents. But if we can, communicate with the IM team and the FM team to tell them exactly where to find PPE, how the hospital system is kind of set up to quarantine these patients, and what floors are we actually using for versus COVID patients. But at this point, it seems like the entire hospital is COVID. So
Mercy, can you regularly get together with the chiefs, like at least once a week, as we get through this?
Dr. Day, you write to me and you come and get your PPE all the time, whenever you want, right? John?
No, the issue is not the PPE. I don't think the issue is access to PPE more than communication as to when results come back for patients. Are you using the quick lab for the results, the local lab?
Not for the patients, no.
What?
Not for the patients, no. We're going to
You should use the local lab for the patients so that you get the results the same day.
We have had some issues with that sometimes we have been sending them and they don't get it done. That's why we reverse back to the one in New Jersey.
So let's talk to Aaron, and we need to do all of the testing, especially patient and employee, has to be done here. And I want the results the same day.
Yeah, employees, we get them rapid. The employees is not an issue. Every employee, resident, everything, they get the rapid test. And we can
No, but there's no reason. Look, the machine can do 1,200 tests a day.
Okay.
So there's no reason why we can't test every single patient if we wanted to. Now, I'm not saying that we're going to test every single patient. I'm just saying that the patients that are suspicious should be tested the same day, and we should get the result the same day.
I think the only reason was Aaron was giving us a hard time, not me, because I never spoken to him, but Billy had said that he was giving us a hard time.
Okay, but Sandy, can you deal with that?
Sure. But I think some of the issues that were coming about was that he only had one guy, that guy Joseph, and sometimes that guy only works like certain hours, and so those were some of the issues we were encountering. We're working with it, but those were some of the issues that we were encountering. So we'll try to get him to work more with us for patients.
Okay, and I guess it's a unique issue for South, so I want to make sure that we deal with it. Mercedes.
Sure.
Okay. All right. And then the other question is, there was a question about what drug. The drug we've been using is soft flu. What is it?
Sofluza.
So I've written this so many times that I don't even remember the name anymore. But yeah, so we have kind of we've been ordering a lot of it. So we've been using it for employees that got exposed, and it's kind of worked out pretty good. At the first onset of symptoms, we give 80 milligrams. Some people have given like 40 milligrams when you have some exposure, like half a dose, but it would have to be significant exposure. But otherwise, as soon as symptoms occur, it probably makes sense to take 80 milligrams.
So we're going to start that. I know you said that we're going to start it here. I know that Palm Springs, they're very reluctant to start it over there. Some of the doctors.
I can't hear you. I can't hear you.
Sorry. So I know we're starting it here for a fact, and I know that on the thread, Alina, Dr. Alvarez admitted that.
Dr. Who? Dr. Who?
Alina Alvarez? Well, I don't know if that's still her.
Alina.
Yes. Palm Springs. You there, Ali?
Yeah, I'm here. Yeah.
They're a bit hesitant to start it on your patients over there is what I read that you put on your chat.
Yeah, but they went ahead. I talked today actually to Del Prado and to Dr. Abreu. I haven't reached out to Frontela or Rocher, but I'm sure they'll be on board as well. But they said go ahead and start it on all their patients. The only one that I think we need to speak to is the director of the ER, because I'm worried about those patients that present to the ER and get discharged from the ER. Like we'll do the test and discharge them. I think we need to speak to them to give them a dose in the ER and then DC them from there so we can, yeah.
Okay, yeah.
So I mean, yeah. And honestly, I don't want any employees or residents to get sick. And if we can treat them early, I'd rather do that than have them in ICU.
Right.
You know.
Agreed. Anything
else?
Dr. Michelle, sorry to go back to the same issue with the PPEs. So on behalf of Team 5, yesterday when I was making phone calls, we have a volunteer who is willing to give us PPE. She is based off Washington, D.C. So I did not know who to, how to route her and everything. So I've emailed you her information.
Yeah, I think I forwarded to Sandy. Did I, Sandy?
What?
Did I forward you that email for the person that was willing to donate PPE or not?
I have the one that that he's donating.
Do you have to wear the mask right now? Because I can't hear you.
Okay, I'm sorry. It's just, okay, so we're gonna contaminate.
No, just Thomas said it's to keep her social distance.
Okay, so yes, I do. This is a problem that we're having. A lot of people want to donate the Chinese NK95. The problem that we're having is neither the nurses nor the residents feel that there's enough of a seal around these masks to protect them. And it's true. When you put them on, there's no seal.
Okay, no, but we're not saying to you, we don't know what kind of masks these are. So Pooja, can you email Sandy? Because maybe I forgot to forward.
Sure, I'll email her the details. I'll forward it to her.
Yeah.
But it's important to know, Jack, that the ones that most people have donated are the KN95s. And John, you might want to elaborate because you're one of the advocates for not using those.
Okay. All right. I don't want to, I mean, we've kind of gone for a long time. I don't want to impose on anybody's time. Does anybody have any last minute questions or comments or anything else?
No, Mercedes and Sandy have been doing a fantastic job of keeping us protected. I just want to say that.
Thank you.
Yeah, thank you,
right.
Mercedes.
Thank you, Mercedes.
Thank you. We haven't had, honestly, we haven't had any issue getting PPE. The packs that you guys have made have been wonderful.
No risk.
No, I can tell you, I've been through, we have an ACGME meeting Mondays, every Monday with all the DIOs, and everybody's complaining about PPE, and actually they don't have PPE. It's not like it's just a complaint about PPE. Is that there's really no PPE, and they're using like trash bags and stuff. So
I just want to complain about PPEs just to complain about PPEs.
Okay, but seriously, I think communication should improve definitely, and I think we should have a plan for early treatment of our staff and our patients. I mean, and our residents.
Hey, Doc.
Yeah.
And Panther's going to be available, correct?
I'm sorry?
The Panther the
No,
testing in
Panther
3
is
hours?
available. The Panther is available. There's been some issues, but I think as of now, Sandy's going to make sure that we use the Panther for. With the Panther's the one that does the results the same day, so that's the one that we're going to use for
Because asking for a friend, I know a friend who's been symptom-free for almost 28 days, and he keeps coming back positive. He or she keeps coming back positive. So the Panther, I think, would help out tremendously, getting them back to work.
Absolutely. And as you all heard, we do have the antibody testing. I don't think there's a clinical value to it, but it's there if we need it. I think it's more epidemiologic value than anything else, but we do have it available already from the lab. So, all right.
Doctor, Paris, I have to tell you, we have another nurse that is not a nurse in our hospital, but it's a nurse in my community, and she has tested 5 times positive, and she has been symptom-free for almost 70 days.
She needs to do hydrogen peroxide gargles.
Are you sure?
No, I'm serious. Because it's an active virus, so she needs to clean her nose with hydrogen peroxide.
I'm going to tell her because she's
and it will go away. I promise.
Okay.
And it's not a Trump thing. It's not UV light or any of that stuff.
Okay, I'm going to tell her because she's
This is really good. All right, guys. Well, everybody have a great weekend, and we'll talk
Hey,
again soon.
this has been awesome, and all the credit. I mean, I'm glad to be on this team. I'm glad to be a part of Larkin. I mean, show the world, and also with our actions. And I'm just thankful for all you guys.
Thanks, everybody.
Thank
Good weekend. Take care.
They heard me.